In this video, we will demonstrate USG-guided technique of stellate ganglion block in a patient of CRPS of upper limb.
Posterior tubercle.
Yes, sir.
The anterior tubercle.
Sir, I think this one.
This one is
So that means this is not C6, this is C5.
We can see C5 anterior and posterior tubercle of same height, C5 nerve root popping out, longus capitis muscle just above an anterior tubercle, and longus colli muscle. Now we are at the level of C6 vertebra, which has prominent anterior tubercle. Here we will deposit the drugs just above longus colli muscle.
That is C6.
If we move little distally, we will see flat C7 vertebra, which has only posterior tubercle. This region has vital structures like vertebral artery and inferior thyroid artery, so it is safer to inject at C6 level, but with larger volume, infiltrate skin with local anesthesia.
Why you are taking 5%, 0.5%? Why not 1%?
large one. You can give
0.5% is sympathetic blocking. Horner syndrome will not be very good, but still diagnostic value is more. Because if you are giving 1%, then what can happen in some subsets of patient, the patient can have a good pen delay because it will be spilling to the brachial plexus, and you will not be able to understand whether this is because of the blockade of the brachial plexus or your sympathetic block. So that's why, though book do not mention, book still mention the 1% is the standard, but I have changed this long back, because otherwise diagnostic value, I have seen a lot of patients where I have done successful sympathetic block with 1% and then I did the RF and no result. So that might be the result, that it might be getting false positive results if you are giving 1%.
We will insert the needle and advance the needle until the needle tip is visualized just above longus colli muscle.
So I'm hitting the tubercle, anterior tubercle.
Yes.
After negative aspiration, 10 milliliters of 0.5% lignocaine is injected and patient is observed for other development Horner syndrome, which indicates successful sympathetic block. This is post-procedure picture of the patient where you can see ptosis on the side where block was given, which confirms Horner syndrome, and more than 70% pain relief was there in the upper limb, which confirms this CRPS pain is sympathetically mediated.